fracture of skull. Skull brain has anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. Anterior cranial fossa may include frontal, ethmoidal and sphenoidal sinuses. It will be accompanied by bleeding through the nose, and if the dura is ruptured, CSF will also come out through the nasal cavity. This is called as CSF rhinorrhea. Rhino meaning nose. Black eye, it is also called as periorbital ecchymosis, can be resulting because of a blow in the eye itself, or it can be fracture of anterior cranial fossa, or it can be bleeding in the fourth layer of the scalp, loose alveolar tissue. So three ways by which you can get a black eye: direct blow on the eye, fracture of anterior cranial fossa, or bleeding in the loose alveolar tissue, that the blood will seep down anteriorly because occipital frontalis does not have a bony attachment anteriorly. The bleeding will come to the eye. Now the black eye was the blood seeping into the eyelid. You can also have a bleeding deeper to the conjunctiva, what is called as subconjunctival hemorrhage. After anterior cranial fossa, you will get fracture of middle cranial fossa. Posterior part of middle cranial fossa forms the roof of the ear, which is called as tegment tympani. If that portion gets involved, then, and along with that, dura arachnoid is also involved, it can result in CSF coming out from the external ear. That's called as CSF otolia, oto meaning ear. Passing through the internal auditory meatus is the seventh and eighth nerve that can get involved. Sixth nerve passes close to the midline of the middle cranial fossa. That can get involved if there is an injury closer to midline. Posterior cranial fossa, if it involves the jugular foramen, 9th and 11th cranial nerve can get damaged. If it involves the hypoglossal canal, 12th nerve can also get injured. Sit together ostro-gold cranium of the skull bone. Skull bones are totally 22 in number, of which only mandible is the mobile one. The others are all sutures and synchondrosis. As the brain growth is completed, the cranial sutures start getting synostosed. Because there is no further brain growth, the sutures are not required. They will get converted to synostosis. So cranial synostosis normally starts occurring by the age of 40 or so and proceeds to the age of 70. But if cranial suture gets synostosed earlier, then you call it as a disease, craniosynostosis. So this is premature fusion of skull suture. What is the purpose of the suture? Let's take the sagittal suture, separating the two parietal bones. Sutures allow growth of head at right angles to the long axis of the suture. The sagittal suture, which is running front to back, allows the head to go transverse. Coronal suture, which separates frontal from the parietal bone, is transversely located. It allows anteroposterior growth of the skull. Sutures normally allow growth of the skull at right angles to its long axis. So if one suture closes earlier, the other suture tries to compensate by overgrowth. Here, anatomic suture between the two frontal bones and normally fuses at the age of 1. But if it fuses before the age of 1, sometimes the intrauterine life itself, the two frontal prominences will be very close to each other. Because the anatomic suture is trying to separate out the two frontal prominences, and if it fuses earlier, the top view of the head will be almost like a triangle. Two parietal eminences and one frontal eminence because close to each other. So that triangular shaped skull is called a trigorocephaly. Here you will notice top view shows coronal suture has disappeared. If coronal suture has disappeared, the anteroposterior growth of the skull will be shorter. So skull's length front to back is short. That's why it is called as brachycephaly. Brachy means short. In contrast, if the sagittal suture has disappeared earlier, coronal and lambdoid suture will continue the head to grow forward to backward. So it will be elongated from front to back. And it's called as scaphocephaly. It's also called as dolichocephaly. So dolichocephaly skull, anteroposteriorly long. If one-sided cranial coronal suture disappears and the other side persists, there will be continuation of growth of the right half in this case and stoppage of growth in the left half. So the skull will be a peculiar shaped head, and that is called as plagiocephaly. Plagio means irregular. If coronal and sagittal suture both fuse early, the only possibility for head to grow is upwards at the squamous suture. Squamous suture almost always never fuses early. So the head will continue to grow vertically up because it can neither grow anteroposteriorly nor transversely. It will grow vertically. Vertically means oxycephaly. Oxy means sharp. So this is what is called as the oxycephaly. You can see the temporal bones are bulging outwards. So the brain is trying to accommodate in this manner. The only mobile bone of the skull and the brain. A person wakes up from his sleep and takes in a deep yawn. Suddenly he realizes And the mouth opens wide, but now it doesn't close because the jaw is disturbing it. Anterior to the mandibular fossa is articular tubercle. If the head of the mandible passes in front of the articular tubercle by overpull of lateral cranial, lateral cranial helps in opening the jaw actively. But if it overpulls and goes into spasm, it will cross the articular tubercle. Then suddenly when it crosses the articular tubercle, the head of the mandible can't go back because the articular tubercle is a bulge. And this bulge comes in the way and the mouth doesn't close. This happens early winter morning when you are expected to reach the class at 8 o'clock, 7:45. So suddenly you realize the mouth doesn't close. You walk into the casualty. So the doctor sees and realizes that he has got a dislocated mandible. What you have to do first is push the mandible back into its socket. But because the articular tubercle comes in the way, that's why you don't close the mouth. So what you have to do first, apply warmth on the cheek. This will relieve the spasm of masseter. Remember, muscles which you cannot palpate, you cannot add warmth to that. But masseter also prevents the closing of the mouth because it assumes the socket is in front of articular tubercle when it is actually behind. So apply warmth so that all the muscles in that region will relax. Then put your gloved finger inside the mouth, mouth is already open, press downwards on the third molar, whatever is the last molar, press downwards. When you press downwards, the entire mandible descends down. Then gently raise up the chin so that the head goes back to its socket. But before you completely close the mouth, remove your finger. And whenever you are testing for mandibular nerve, never ever test by putting the finger in between teeth and asking, bite hard. You will chew off your finger, even if half muscle diameter. Testing of mandible is always done for investigation, is always done by asking the person to open the mouth or exhale, not close the mouth. So anyway, after it has gone back to its socket, in order that it doesn't yawn again, you tie a bandage from the top of the head to the bottom of the chin. Wrap it around multiple times and keep that bandage wrapped for 7 days. Because you want the ligaments to heal, right? And because head region is highly vascular, the healing occurs faster. If you have lower level ligament tear, it results in years, sometimes not even in 14 days. Head region, of course, how will you eat food, drink water, etc.? You can temporarily remove that bandage, eat food, drink water, etc., but no yawning. That's why I do it. And this tying should be especially done at the time of sleeping, because you know very next day is going to get up for the 8 o'clock lecture again. From 8:30 is already late. And yawns again. So you don't want you to go into that deep opening of the mouth. The upper jaw is supplied by posterior superior alveolar, middle superior alveolar, and anterior superior alveolar artery, which freely anastomoses with each other. The lower jaw has got only one single artery, the inferior alveolar. So, block in any one of the artery, any one branch of the artery, and with extraction of teeth, will result in infection of the jaw along with the socket. That's called osteomyelitis. hangman's fracture. So hanging are of three types. One is called suicidal hanging, the other is called homicidal hanging, the third is called judicial hanging. In suicidal and homicidal hanging, usually the choke is on the trachea and he stops breathing and then thus he dies. In judicial hanging, what usually happens is there is a fracture of the odontoid process of the skull, of the axis vertebra. The odontoid process is held in position by the transverse ligament of atlas. And transverse ligament of atlas is called as the most important ligament in the body. If the transverse ligament of atlas breaks, usually it does not, but if the odontoid process is disconnected from the second cervical vertebra, the second cervical vertebra along with the vertebral column turns backwards. But immediately behind the vertebral body lies the spinal cord, and the spinal cord will get crushed. So if C2 is a bone which is broken and it turns backward, crushes the spinal cord segment C2 is crushed. Below C2 is C3, C4, C5. C3, C4, C5 is from where the phrenic nerve arises. And because the phrenic nerve has been disconnected from the respiratory centers in medulla, the person stops breathing. And that's how he dies. So, a sudden fracture of C2 vertebra, crushing the spinal cord, instantly makes the person unconscious. So all that his body is moving is actually a reflex movement of the body. He does not feel the pain. So it's going to be painless then. That's judicial hanging. This is a neonatal skull. It can also be a fetal skull. Somewhere around this around the time of birth. Different colors are shown for the different bones, so that you get an idea. What you are seeing, that red colored bone is the literally was sphenoid, temporal frontal parietal. That's the reason it's called a pterion. And posteriorly, between parietal temporal occipital is asterion. So the pterion and asterion are usually the terms that are used in adults. In the child, all four corners of parietal bone, there are spaces to allow brain to grow and other reasons. This is called as fontanelle. So there is an anterior and posterior fontanelle in the midline, and anterolateral and posterolateral fontanelle at the corners. These fontanelles have got multiple reasons why they are present, and what are their significance. We will discuss that. Metabolic suture fused at the age of 1. So this is the fetus or the newborn. Metabolic suture is present. There are 4 sutures which meet at the adult point called brain bone. But here it is called as anterior fontanelle, diamond shaped. In contrast, the posterior fontanelle is triangular in shape. Because there are 2 parietal bones and 1 occipital bone, so it's triangular in shape. When the child is being born, a pervaginal examination can tell the gynecologist whether the person is coming with skull and head facing forwards or backwards by palpating the anterior and posterior one. So you can say whether head is forward, head is backward, because management of the newborn birth is according to how the head is faced. portals help in molding the skull during parturition or childbirth. That's the primary function of the portal. After birth, most of the portals close by around 2 to 3 months or 4 to 6 months. Only the anterior portal persists for 18 to 24 months. So childbirth is completed. The anterior portal continues. So anterior portal allows the rapid growth of brain. Brain growth is faster than bone growth. So when the brain is rapidly growing in the first 2 years of age, 90% of the brain growth is completed by age of 2. And anterior portal allows that rapid growth of brain. So these 2 points are called as functions of portal. Now the clinical application of portal. If the baby is dehydrated, the anterior portal will sink in, and if there is a raised intracranial pressure, the portal will bulge out. Okay, so this is the clinical application. If the portals are sunk in, dehydration of the baby. If the portals are bulging out, it's not overhydration of the baby, overhydration of the brain. That is called as raised intracranial pressure. Then there are surgical applications. Portals can be used to collect CSF from the lateral ventricle. Go from the corners of the diamond-shaped anterior portal, put in a needle in through the dura, rectoid, via brain, and put it into the lateral ventricle. So you say, you're passing through the brain, and needle tip of the brain damage through the so-called what is called a silent area of the brain does not produce any effects. Why would you collect the CSF in this manner? Why not collect it from the simple lumbar puncture which you do in adults? Remember, lumbar puncture can be done when the spinal cord reaches L1 vertebra to the space L3-4. In the newborn, the spinal cord extends up to L3. So you can't do lumbar puncture below that. Too dangerous. There is an alternative, what is called a cisternal puncture. You can put in a needle from the back of the head through the foramen magnum to reach the cisterna magna, the cerebellomedullary system, and collect the CSF. But suppose the foramen of Magendie and Luschka, and suppose the intraventricular foramen of Monroe or the aqueduct of Sylvius is blocked, then the ventricle will keep enlarging at the compromise of the brain tissue. So we have to remove fluid from the lateral ventricle. So you have to do a ventricular CSF, then you can use this by going through the corner of the water. This can be done only in the age of 18 to 24 months, after which the water will close. This is a surgical application. Another surgical application is if you want to collect blood from the superior glands. Blood can be collected from very many areas. If you want the sinus blood, you can go to the midline of the anterior portal. Immediately below that is superior gland. So 2 functions, 2 clinical applications, 2 surgical applications. Here what you see is that the anterior portal is sunken. In the left hand side what you see, not see actually, will be on the screen. From that side you can see that the anterior portal is bulging out. So there is intercranial pressure on the left side and dehydration of the baby organized. So people say, applied anatomy of scalp. Scalp has got a lot of sebaceous glands. So sebaceous cysts are possible in the layer 1 of scalp. Sebaceous cyst is possible in layer 1 of scalp is a pathological state. Where is the application of the knowledge of anatomy? Remember, applied anatomy has to be an application of anatomy. Without any application, just making a statement, inflammation of trachea is tracheitis. That's not anatomy. That's pathology. Anatomy you have to have a basis for it. So, scalp wounds lead to what is the anatomical basis of this? And the second layer of scalp has got dense connective tissue. This dense connective tissue holds the tunica adventitia of the vessels open, doesn't allow it to collapse, doesn't allow the vessels to retract, so the scalp moves, and moves. Religions used to hold the head of the victim, hair of the victim, and pull it back. This is called a de-scalping. So all 5 layers of the head will come out, and you will get the periosum. Periosum will also come out. You see the skull there. And the person at the edges of the wounds bleed to death. Then, if they are cannibals, they take the flesh. Otherwise, this is how they kill the enemies. This scalping. If the head is bleeding, apply pressure on the bleeding side. But that de-scalping, even though periosum is removed, does not cause the skull bone to undergo necrosis, because the main blood supply of the skull comes from the meningeal vessels from within. So that it does not mean that the necrosis of bone is pathology. But the reason for that is because there is a blood supply from within in applied anatomy. Wounds across galea purulotica cape. Galea purulotica is an intermediate aponeurosis between the occipitofrontalis muscle. Occipitofrontalis muscle are running from back to front. The aponeurosis also runs from back to front. If you cut, if the wound go deep enough to cut the layer 3 transversely, the frontal belly and the occipital belly will pull in opposite direction and the wounds will gape. If the occipitofrontalis galea purulotica is cut longitudinally along the fibers, then the wounds will not gape. Whether the wounds will gape or not gape, depends on whether you cut across the fibers or along the fibers. Loose angular tissue causes lacunae because the blood will seep out. Injury can be used in the top of the head, a vertex. Blood will gravitate down to the forehead and then go to the upper eyelid, and the corners of the eyelid will also go to the lower eyelid. And then the eye will be turned initially deep blue, after some days it will become greenish, then yellowish, and then finally the normal color. So it never is really black, because it is black. Infection of the loose angular tissue has got one more importance, and because there is a parietal emissary foramen, except the emissary foramen are valvulous. So this allows external infection to go inside. So dangerous side effect. In fact, veins we say have valves, but some veins do not have valves. One of them is this. So I'll give you a list of veins which do not have valves. Whereas there can be a papular vein. Very small veins do not have valves. Very large veins do not have valves. Head neck veins do not have valves. Pelvic venous plexus has no valves. Portal system of veins don't have valves. Cardiac veins don't have valves. Vertebral venous plexus, internal and external, do not have valves. All the remaining veins have valves. This is head neck vein, so it will have no valve. Sometimes there is bleeding below the periosteum, which is called as cephal hematoma. The cephal hematoma is bleeding below the periosteum. And where the bones terminate at the sutures, the periosteum will turn inward and not pass across the sutures. So cephal hematoma will be restricted at the suture line. It will take the shape of the underlying bone. In contrast, when you have a child with vacuum delivery, I don't have to explain this vacuum delivery because it was very well explained in a movie which you all must have seen at some time in your life. So that results in fluid accumulation below the vacuum cup. That fluid accumulation is called as caput succedaneum. The shape of the caput succedaneum will be the shape of the vacuum cup. So it does not bother about suture lines and other. Whenever you put the vacuum cup, underneath that, there will be a slight bulging. So obviously the child which was shown in the movie did not show caput succedaneum. So it was not a vacuum delivery, it was showing as if it is a vacuum delivery. This is the communication of the parietal emissary foramen to the superior celiac cells. This is how the reddish colored black eye is seen. It starts off with blue color because the blood which is accumulated there will be having lesser of oxygen, so it becomes cyanosed in color, and then it becomes bluish, then it becomes brownish, greenish, yellowish, peri-orbital ecchymosis. Makes you so much more learned instead of saying black eye. Peri-orbital ecchymosis. You can see on the upper right, you can see a sharp outline of the swelling along the suture line. So that is cephal hematoma. In contrast, in the lower part, lower left, you can see there is a generalized swelling in the just behind the vertex. Generalized, that's caput succedaneum. And what is the difference between these two? Caput succedaneum will occur in the presenting part of the head because that's where you are going to apply the vacuum. It crosses the suture line, stays only for 3-4 days and does not require any treatment. The swelling will go after it's fluid accumulation. Cephal hematoma, because of blood clot, it will take a longer time. If it gets infected, then you have to treat it with antibiotics. Otherwise, it also goes on and takes a longer time. The lower nose and upper lip is called as a danger area of the face. If there is infection there, boils or whatever, and you press them deep, then you are pushing the infection backwards, upwards, which can go into the internal cavity and cause thrombosis of the dural venous lines there. The nasal region spreads through a different part, the oral region spreads through a different part. We'll have a so from the nasal region, angular vein, which is flowing towards the angle of the eye, angular vein, normally drains away from the angle. Because you press upon the infection of the node, it will flow in the reverse direction, angular vein, which communicates with superior-ophthalmic vein, and superior-ophthalmic vein communicates with cavernous sinus. From the oral region, there is a deep facial vein which drains the infection to the pterygoid venous plexus. Pterygoid venous plexus are within the lateral pterygoid muscle. But then this has got a communication of emissary vein to foramen vein into the cavernous sinus. So that is a communication of infection from the upper lip to reach the cavernous sinus. Cavernous sinus, remember, has got third, fourth ophthalmic maxillary, sixth cranial nerve, and internal carotid artery within it. So when the cavernous sinus gets thrombosed, it can affect any or all of these structures. Trigeminal neuralgia is a medical term. Thick doloroo is an English term, a French term actually, because all those X, etc. are silent. It is do, lo, ru. It's a thick doloroo, which is called trigeminal neuralgia. Any nerve which has got a sensory distribution, that nerve is affected, you will feel pain, severe pain along that distribution of that particular nerve. So, trigeminal neuralgia will affect the trigeminal region. You can get isolated ophthalmic neuralgia, maxillary neuralgia, mandibular neuralgia, or generalized trigeminal. The entire face region will be painful, with the exception of the angle of the jaw. Because angle of the jaw are supplied by great auricular nerve branched from cervical plexus. So that portion will not in the pain, the rest of the region will get the pain. So, you got the ophthalmic nerve, maxillary nerve, and mandibular nerve, which can be, when the pain is so severe, what you need to do is you need to inject a needle into that region and block the nerve. So, if it is ophthalmic division, you can block the supra orbital nerve, which is the branch of ophthalmic. You will say, supra-orbital nerve, is this a branch of ophthalmic? What about other regions? Remember, when you are injecting an anesthetic agent forcibly along the sensory nerve, the anesthetic agent will backtrace along the nerve and go to the main trunk and block the main trunk. If there is maxillary neuralgia, select the site B, which is where the infraorbital nerve comes out. Forcibly inject the needle there, anesthetic agent will backtrack and block the whole maxillary division. And if you go along the frontal nerve, point C, in backtrack and block the entire mandibular nerve. So the anesthetic agent can be injected at different sites to block the different divisions of trigeminal nerve. Because the neuralgic pain is so big, the first job is to relieve the patient of the pain. Usually some viral infection or some such thing, after a few days it is okay. But those few days are terrible. In contrast, if all the three divisions are painful, it is better to block the main nerve itself. So if you see the sign along the lateral part of the cheek between the upper lip and lower lip, you pass a little angle so it goes into at the base of the skull where you inject the dye. You go and block the trigeminal ganglion itself. So all the three divisions are taken care of by one single shot. Is the dura painful? What dura is not painful? But the cranial dura are painful. Electron and fire do not have sensory nerve fibers. They are weightless. But dura, base, cranial base dura is painful. And structures where the vessels pierce the dura are painful because the dura is inside the nerve space. When you do a lumbopulmonary and remove CSF, the intracranial pressure drops. When the intracranial pressure drops, the brain and the dura moves. That results in pain. Because the intracranial pressure also drops. So as the person will lie head low. So that there is head will be adequately hydrated and the tug of the dura will not be there. So that's good enough. And divides the pain. Or headache that you get after you remove CSF. Tentorium cerebelli, supratentorial region is supplied by ophthalmic division. Then is supplied by trigeminal nerve. Infratentorial is supplied by C1 to C4. So that meningeal branches of vagus and hypoglossal is not seen. It is like meningeal branch of hypoglossal, meningeal branch of vagus. They are actually carrying C1 to C4 fibers. So, vagus and hypoglossal do not supply dura from their fibers. They are borrowed fibers from C1 to C4. Because infratentorial dural pain is felt in the back of the head and neck. They have the same distribution of C1 to C4. C1 doesn't supply skin, but C2 and C4 does. Lepto means thick. Pachy, P-A-C-H-Y, means thick. So pachymeninx is dura. Leptomeninx is the electroid fire. So when we say meningitis, brain infection, actually meningeal infection and usually leptomeningeal infection, not dural infection. Leptomeningeal infection will spread through the subarachnoid space because between the arachnoid and fire. When there is meningitis, the blood CSF barrier breaks down. When the blood CSF barrier breaks down, that allows antibiotics to enter the renal cavity and tackle the infection. If there is no meningitis, no breakdown, then most of the antibiotics do not enter the renal cavity, do not enter the CSF. wonderful for us that when there is going down, you require antibiotics to reach, it will go through because brain barrier is not broken. Broken down, but here the problem is fungal infection of the brain does not cause breakdown of blood-brain barrier. So antifungal drugs are of no use in fungal infection of the brain because an antifungal drug never reaches the CSF. So what you need to do is a severe fungal infection of the meninges, you have to do a lumbar puncture and inject the antifungal drug directly into the lumbar CSF. And then along the rest of the CSF, it will flow and tackle the infection. So this was lumbar, the therapeutic effect of lumbar puncture. Lumbar puncture are for diagnostic and therapeutic. If you have fungal infection, you can do it. And of course, it has also got the job of anesthesia. So diagnostic, therapeutic, anesthetic reasons why lumbar puncture is done. But before lumbar puncture is done, you have to make sure that the person does not have a raised intracranial pressure. A raised intracranial pressure, if you do a lumbar puncture, suddenly the brain will collapse, sink down, because sudden drop in pressure will cause the tonsils of the cerebellum to herniate out of the foramen magnum. The tonsils of the cerebellum herniates out through foramen magnum, vertebral artery which is entering foramen magnum will get compressed. This is called as खुद के पैर में कुल्हाड़ी मार. So you have to make sure that the person does not have a raised intracranial pressure. So how do you see that? You observe the brain. You see the brain. Is it bulging? There is raised pressure. Observe the brain. The only part of the brain which can be visualized in a living person is the retina of the eye. The retina of the eye, remember, is an extension of the brain, and when the optic nerve enters the retina, that's called papilla. So through an ophthalmoscope, you visualize the retina, you see the site where the optic nerve enters. If that area is swollen, what is called as papilledema, which means the rest of the brain, CSF is also swollen. It's raised pressure. Don't do lumbar puncture. So lumbar puncture is contraindicated when there is papilledema. That's why sometimes it's a medicine resident who does a lumbar puncture. He calls an ophthalmologist, come and have a look at the patient. Because he has not learned how to do a retinoscope. So ophthalmologist should see and gives the good signal. You can do lumbar puncture because there is no papilledema. If there is papilledema, don't do lumbar puncture. This is a coronal section of cavernous sinus. You can see on the lateral wall and the oculomotor, trochlear, ophthalmic and maxillary. On the medial wall is abducens and internal carotid artery. All these structures are separated from the arterial blood by endothelium. But cavernous sinus, when it gets thrombosed, it can affect any or all of these cells. Sometimes the cavernous sinus, of course, when cavernous sinus is thrombosed, the ophthalmic veins, superior and inferior, which are draining into the cavernous sinus, will get blocked and the eyes will bulge outwards. It's called exophthalmia. If the internal carotid artery, which is like the cavernous sinus, if it gets ruptured here, the internal carotid artery will pour its blood into the cavernous sinus with each heartbeat. So with each heartbeat, blood enters the cavernous sinus and goes out. So with every heartbeat, the eyes will throb outward. It's called a pulsating exophthalmia. So cavernous sinus thrombosis, exophthalmos, with involvement of any of the nerves, when artery bleeds into the sinus, pulsating exophthalmos, and the eyes will bulge out with every heart. Oculomotor is also a very peculiar nerve. On the outer side of the oculomotor nerve, there is muscles which are supplying the intraocular muscles, the ciliaris and the occipital pupilla. In the inner part of the oculomotor nerve is the nerve which supplies the extraocular muscles. So superficially located are the parasympathetic fibers, deeply located are somatic efferent fibers. Therefore, external pressure of the eye will result in pupillary changes, whereas diabetes vasculitis, their vessels are involved. The inner part of the oculomotor nerve suffers from lack of blood supply. Outer part will get more blood because blood vessel comes from outside. So diabetic retinopathy causes total ophthalmoplegia, whereas pressure from outside will produce pupillary change. Exactly similar is the recurrent laryngeal nerve. The fibers of the recurrent laryngeal nerve will supply the abductors of the larynx lying outside, so they never suffer from lack of blood flow. But that also means if a surgeon partially damages the recurrent laryngeal nerve, the abductors get paralyzed first. This is the bulging left eye because of cavernous sinus thrombosis. Also you see that the eye is closed. And because of the bulge, he is trying to protect it. And the limiting conflict which is supplied by third term is involved. So it can't elevate that. We discussed this when we discussed extradural hemorrhage. There is a little details of the same thing. When there is a head injury and the person loses consciousness immediately, that is called cerebral concussion. It's a reflex shutdown of the brain to prevent any other jarring effects. Reflex shutdown can be a few seconds to a few minutes. And if it's an extradural hematoma, you may wake up because it takes time for the extradural hematoma to be actually pressing on the head. Usually any vascular injuries, either intracerebral or any other intracerebral, subarachnoid, extradural, subdural, all of these produce a lot of swelling, cerebral edema. So part of the treatment is to reduce the edema first. How do you do that? You introduce mannitol in the blood. Mannitol is hypertonic. So to enter the cerebral vessel and to absorb the fluid from around the brain. Because the hypertonic solution, water will enter the edema is reduced. There is another type of head injury which is called as coup injury. Coup. That P is silent. And contre coup. If somebody takes a hammer and bangs you on the left forehead, you get an injury there. There may be fracture there, underlying brain, frontal lobe will get involved. This is called as coup injury. External rotatory structure comes and hits your head. And then the other way around. The object is stationary, your head rotates. That means you are falling down and you have fallen on the left forehead. The left forehead has banged against a stone. Unyielding stone, head hits there, you get a fractal injury, that's called coup injury. But when you are falling down, the head is moving down, the brain is moving down, the CSF is moving down. Sudden break of the skull doesn't stop the inertia of CSF. CSF will continue moving down. Skull has stopped moving, CSF is moving down because of inertia. And large accumulation of CSF goes to the site of injury. That can result in the brain being pushed backwards at a diametrically opposite side. So you have got a left frontal lobe damage, CSF rushing there, pushing the brain backwards to the right side. So you get, along with left frontal damage, you get right occipital damage. That is called as contrapunct. So you find that the patient has got visual disturbance. Then you start wondering, frontal lobe is supply visual area. Remember, when the person has rotated and gone to hit the stone, then we have contrapunct injury on the opposite side. Coup injury can be easily observed, there will be bruising and all those things. Contrapunct injury are hidden because they are inside the head. Similarly, if you hit the left side of the head, right temporal lobe will show contrapunct. Left temporal lobe will show coup injury. So you must keep in mind coup and contrapunct. As I said, this will not happen if some object has come and hit your skull. There is no inertia of CSF. Object has hit the skull, you will only coup injuries. When the head has hit the object, you can get coup and contrapunct. He simply states that the volume of brain, blood and CSF is constant. So if there is an extradural hemorrhage, blood is increased, that means the compromise of CSF and brain. Whether it is extradural hemorrhage or a subdural hemorrhage or a subarachnoid hemorrhage or intracerebral hemorrhage. In all these cases, as I said, cranial cavity is a fixed space. Blood, CSF, brain, total sum volume is equal. When one rises, it's at the cost of the other two. The extradural hemorrhage can have the period of lucid interval. First unconsciousness concussion, second unconsciousness contusion. Whereas when it comes to subdural hemorrhage, such lucid interval is not occurring because now it is within the dura. Only thin layer of meninges separating the blood from the brain. It's very early impression of the brain. So concussion and contusion are continuous with each other. So the unconscious is unconscious. No lucid interval in between. Subarachnoid hemorrhage is usually due to a vessel rupturing in the subarachnoid space. And small dilatation of vessel in the subarachnoid space is called aneurysm, described by a scientist called Berry. It's called Berry aneurysm. So extradural hemorrhage is usually arterial, subdural hemorrhage is usually venous. Some electrode hemorrhage is arterial. Intracerebral is also arterial. Here on the left hand side, the red color is the extradural hemorrhage. You can see the shape in like a biconvex lens. On the right hand side, what is blue color is the subdural hemorrhage. As you can see, it is shaped like a concave or convex lens. The extradural hemorrhage produces the brain to herniate below the fox cerebri. That's called a subfalcine herniation. Subfalcine. Later on, the pressure increases further, and the uncus of the temporal lobe will herniate through the tetoidal notch. That's called an uncal herniation. Uncal herniation is what produces the pupillary changes. Later on, the cerebellum tonsils can herniate the foramen magnum. That's called as tonsillar herniation. And of course, if there is this break in the skull cap, calvaria, through that the brain can burst out. That's called as transcalvarial herniation. Remember, hernia by definition is an abnormal protrusion of a visceral part through a normal or abnormal opening into a preformed sac. The preformed sac here is dura erectile as a sac between the brain and ribs. When you see the blood vessel artery and you see a small swelling of the artery, that is the aneurysm. Such very aneurysms are present in most of us. In some of us, it will rupture, giving rise to severe body damage. Rupture is more likely in a person who is hypertensive. That is pressure of the blood vessel, there is chance of the rupture. As age advances, the artery does not bulge. If it doesn't bulge, it will break. So छूटते नहीं, वो कटते हैं. What's the time?
11:57.
I think we will stop here because of the cervical fistula. We done enough for today. The next lecture will be on Saturday, Tuesday, and Thursday. That's the last lecture because from next Saturday onwards there will be university exams. Then this hall will not be available. So for both anatomy and visual lecture,